I'd like to thank the organisers for asking me to speak here today about driving and flying guidance in syncope patients. My particular interest in this area is I'm a cardiology advisor to the CAA, and for my sins I was tasked, amongst others, to produce or to update the guidance for pilots with syncope. So when dealing from a regulatory viewpoint with syncope and drivers or pilots, it's clearly very important to maintain a balance between maintaining public and even personal safety, but at the same time not unfairly impacting on an individual's daily life or jeopardizing their livelihood by removing their license. So if we go straight to the DVLA and driving, they produce a very nice booklet called Assessing Fitness to Drive, which has been updated very recently in March 2019. And they use a traffic light system. So for any particular clinical scenario, green means you may drive and need not notify the DVLA. Amber means you might be allowed to drive if you meet certain conditions, and red means you must not drive. Now, unfortunately, for transient loss of consciousness and syncope, there's a lot of red in the guidance. So what's the principle that the DVLA work on? So the general principle across all conditions is that for a Group 1 license, that's somebody who just wants to drive a car, then the acceptable risk of incapacitation is up to 20% per annum. If you have a Group 2 license, that is, you want to drive a HGV or drive a bus, then the acceptable risk of incapacitation is much lower. It has to be less than 2% per annum. Now, when the DVLA drew up their guidance for TLOC and syncope, they took into account the three mitigating factors, the three Ps, with which most of us will be familiar. So they want the episode to have occurred while standing and not sitting or driving, that you have a decent prodrome that will allow the driver to pull over, and that there is a significant provocation, such as an intercurrent illness with vomiting or diarrhea. I don't want to get into too much nitty-gritty, but if we take a single episode of transient loss of consciousness and you hold a Group 1 license, i.e. you drive a car or a motorcycle, if you have typical vasovagal syncope that happened while standing, you get a green light, so you can continue driving and you don't have to notify them. If, however, it occurred while you were sitting, you may be able to drive and need not notify the DVLA if you've got an avoidable trigger which will not occur while you're driving. Otherwise, the 20% rule kicks in. You mustn't drive until your annual risk of recurrence is assessed at below 20%. It's more stringent, as you might expect, for a bus and lorry driver. Even if you have typical vasovagal syncope and it occurs while standing, you have to notify the DVLA and not drive. They don't say how long you're going to be off particularly, but I suspect it will take a few weeks before the paperwork goes through. If the episode of vasovagal syncope occurred while sitting, you must not drive for 3 months and you have to notify the DVLA and be investigated. It's relatively similar for syncope with an avoidable trigger or a reversible cause. If it happened while you were standing, you may drive and not notify the DVLA, but if it happened while you were sitting, you can't drive for 4 weeks. And again, similar type of restriction to above for the bus and lorry driver. I don't want to just read all the guidance off. The principle, however, is if you look at the lower line here, this is a person with a Group 1 license. So if you've got very typical vasovagal syncope with precipitating factors, you may be able to continue driving. As you move on to cardiovascular causes that are not typical for vasovagal syncope, you may be off for 6 months. Again, if you've unexplained or syncope or an unreliable prodrome, again, you will be off. If you are a HGV driver, you'll be off for longer. And if you get over to this category where the blackout may have been a seizure, if you're a HGV driver, you're off for 5 years. So that was for a single episode of loss of consciousness. What is the chance of you having recurrent syncope? Well, if we look at a population basis from the Framingham study, they looked at about 8,000 patients and followed them for 17 years. And about 10% of those individuals had a syncopal episode over that time. And the incidence of a first episode of syncope was about 0.6% per annum. It occurred more frequently in the elderly, and vasovagal syncope was the cause in about 20%. For those with syncope, about 80% over that 17-year period had only a single event, and 20% had recurrent events. But your hazard ratio of a recurrence, if you have one episode, is about 25. If you then move on to a more selected population, this is data from the Mayo Clinic, where they had about 4,000 patients over a 3-year period. And you can see this is a pretty skewed set of data in my mind, in that 10% had syncope while driving. I don't think that's standard experience, really. But even in individuals who had syncope while driving, a vasovagal mechanism was still the most common. Interestingly, if you look over here at the recurrence rates, by 3 years, the chance of a recurrence was somewhere between 20 and 30%. And the people who had syncope while they were driving initially actually had marginally less episodes, not really significant. So it doesn't matter whether you presented with a syncopal episode while you were driving or you were one of the general population, there was no difference in the incidence of recurrent syncope. Now, the question that isn't answered in that paper is whether if you had syncope while sitting the first time, were you more likely to have syncope while sitting the next time? Their recurrence rate over 8 years while driving was 7%. So the DVLA, when they're drawing up their guidance for recurrent episodes of loss of consciousness, they use a recurrence rate of 20 to 30%. The next episode will usually be within 3 years of the first event, and 80% of these patients will have at least one additional event within 2 years. So their guidance is very similar. If you drive a car or a motorcycle and the episode occurs while standing and it's typical vasovagal syncope with an identifiable, consistent prodrome, you can continue to drive. If it happened while you were sitting, you must not drive until the annual risk of recurrence is assessed at below 20%. You may drive and need not notify the DVLA if there's an avoidable trigger, which won't occur while driving. Otherwise, you can't drive until the risk of recurrence is less than 20% per annum. Whereas for a HGV driver, the risk must be less than 2% per annum. So if we try and look at this, if you look at the histogram, blue is a single episode of syncope. The greens are multiple episodes of syncope. If it's typical vasovagal, the restriction may not be for too long. If you move over here to unexplained syncope or an unreliable prodrome, if you're a HGV driver, you're off for 12 years. 10 years. And if you have recurrent blackouts with possible seizures, you fall off the curve completely. So to move on then to syncope and flying, I thought I'd just say a little bit about syncope in airline passengers. There's actually no real guidance regarding this. What are the factors that may promote syncope in flight? Well, we all realize that immobility plays a major role, especially if you're traveling in the back of the aircraft. Hypoxia may play a role. There will be a low PO2 as the cabin is pressurized at 7,000 to 8,000 feet. If you look at the partial pressure of oxygen at sea level, it's about 14 kPa. By the time you've gone up to about 10,000 feet, the kPa is about 40% down. But fortunately, because of the shape of the oxygen dissociation curve, even at this level here, your O2 saturation will still be above 90%. So although you've lost 40% of your kPa, your actual oxygen saturation remains reasonable. Dehydration may play a role. Cabin humidity runs about 15 to 20%. Alcohol often plays a part, and then the stress of flying and the early morning start. So this is data from a ground-to-air medical advice center from the States. They had about 12,000 call-ins, which meant that there was one medical emergency per 604 flights. And syncope or pre-syncope was the commonest reason for a call. Physicians provided assistance in about half the time, and aircraft diversion occurred in 7%. So if we look at the hazard ratios for aircraft diversion, it turns out that in fact syncope is the least likely thing to get them to turn the aircraft round. So the hazard ratio is 0.82. If a doctor came and looked after you, the hazard ratio was 2.3. It's hard to know whether that's cause or effect. And I would suggest a little bit of caution about traveling with airline number 3. The hazard ratio of turning around the aircraft was 0.49. They're not going to turn around whatever happens. So if we then look at licensing for aeromedical personnel, well, there are different classes of license as you might expect. So the typical person we think of as a pilot is the commercial airline pilot, but also North Sea helicopter pilots, some flying instructors, or people who fly air ambulance, all have to hold a Class 1 license. If you want to fly solo, you have to have an unrestricted license. So your annual risk of incapacitation has to be really very low, less than or equal to 0.25% per annum, or at least as good as your peers. If you can't make that standard, you can have an operational multi-crew limitation, an OML on your license, provided your risk of incapacitation is less than 1% per annum. So that will allow pilots to fly in a 2-crew environment, post-CABG, PCI, or pacemaker, and even in the UK at least, you can fly with an asymptomatic brigada pattern, which you do need to fulfill pretty strict criteria. A Class 2 license is one notch down from a commercial airline pilot's license, and probably inappropriately, that was the only kind of license you could fly with as a private pilot in a European country until quite recently. So the standard is equivalent to a Class 1 with a restriction. But with that license, you can instruct private pilots, and you can also fly an aircraft of any size, but not passengers for hire or reward, and that's been in the news fairly recently. If you're an air traffic controller, the standard is equivalent to a Class 1 with a restriction. If you look at what you would consider more typical private flying, this is a light aircraft of less than 2,000 kilos. There is a new license called a Light Aircraft Pilot's License, which is a LAPL, and that allows you to fly in European airspace now. But now, to fly solo, you just have to be able to drive a car. So that's really quite a jump. So your risk is 20% per annum. I'm not sure whether it's right, but that's where the rules have gone. And you can carry up to 4 passengers if you meet the DVLA standard. That's a 2% per annum risk. So where does the 1% per annum come from? I'm always a little dubious about the number of suppositions made in this, but this is the standard approach that is had in aeromedical circles. The acceptable risk of a crash is 1 in 10 million hours. And of those, only 1% are allowable to medical failure. So there's a 1 in a 10 to the 9 chance, or allowable risk of a crash due to medical failures is 1 in 10 to the 9. Now, fortunately, every syncopal episode in a pilot or an incapacitation doesn't result in an accident. If we model it on a 30-minute or 60-minute flight, where the most crucial bit is the 3 minutes in ascent and the 3 minutes in descent, if you look at it in the for two pilots, there is a 1 in 1,000 incapacitation will cause a crash. So that's from simulator work. So the acceptable risk of incapacitation is 1 in 10 to the 6 flying hours. So that's 1 in a million flying hours. As there are 10,000 hours in a year, if you have a condition that will incapacitate you once in a year at a risk of 1% per year, that means there is a 1 in a million chance that you will be incapacitated during that flying hour, which just brings you into this zone. So when faced with a pilot with a transient loss of consciousness, there are the usual potential mechanisms: cardiac, neurological, and the more troublesome ones really are the unknown and the vasovagal episodes. If you've got a straightforward cardiac cause like an SVT or heart block, and you've had a syncopal episode, you're going to have it fixed before you can fly. If, however, you have a vasovagal episode, particularly if it's recurrent, you're otherwise completely healthy, but it clearly causes major issues if you're going to be an airline pilot. So the key questions for us are, what's the likely recurrence of vasovagal syncope in a pilot population? What effect do the non-pharmacological or pharmacological interventions have? How do we best risk stratify? And how long should the pilot be unfit after one or several episodes of syncope? And when, if ever, can they fly without a co-pilot? So first of all, do non-pharmacological treatments make a difference? So if we look at the data from the Netherlands, from the STAND study, they looked at individuals with fairly frequent syncopal episodes, at 3 or more episodes in the preceding 2 years. And 30% of them had had injuries, so quite a symptomatic group. If they are then trained in all the non-pharmacological methods of avoiding a syncopal episode, they still have a 49% recurrence rate at 12 months. So it's not wholly reassuring. But the median number of syncopal episodes at 1 year was reduced from 3 to 0. So it clearly has an effect, but it doesn't abolish the problem. We're going to hear a lot about non-pharmacological treatments as well from Professor Raj, but the work from Professor Sheldon in the post-1 study and the post-2 study, although when you began to look in more detail at the work, there were groups who benefited, overall the results were not that impressive. Actually, they were negative in terms of the primary endpoints. The midodrine from the STAND study, again, I was surprised it was negative, but we're going to hear the post-study coming out, I would hope, in the next year or so, and that will give us a better idea of whether midodrine, we all suspect it's effective, but we won't know for a while. If we then look at the post data from the post-1 study, the inclusion criteria, to see whether a recent history or a lifetime burden is a better predictor. For the post-1 study, you had to have at least 3 lifetime episodes of syncope, of vasovagal syncope, with a median of 8, and the number in the last year, you had at least 1 prior to the study, and a mean of 3. So if we look at the left-hand graph, this is the number of episodes in the year before you went into the study. If you'd had 0 or 1 episodes, your chance of having syncope over the next year was about 20%. If you had had 2 or 3, it was about 40%. And if you had more than 6, it was about 70%. So there's quite a nice separation with risk stratification there. If you look at the lifetime episodes, there's much more bunching in the lower frequency episodes. But importantly, if you got into the post-1 study, even if you had no syncope in the year preceding, you still had a 7% recurrence rate. So for a pilot population, if you can get into the post-study, you probably shouldn't be flying. So fortunately, most pilots will not have had more than 3 episodes in their lifetime, so wouldn't have got into the studies, and many will be naive to simple avoidance measures, increased salt and water intake, and physical countermaneuvers. So when trying to draw up the guidance, the factors we took into account, rightly or wrongly, are that I think logically a single episode will result in less restriction than multiple episodes, and we sort of used the DVLA work that the more mitigating factors present, there will be less restriction. But in addition to the 3 Ps, it also should not occur in an aviation environment. And the recent frequency may be more important than the lifetime burden. So if you have a single episode of vasovagal syncope and you have all the mitigating factors and it wasn't in an aviation setting, you can go back flying after a week. If that isn't the case, you're going to get further investigations and greater restrictions. Now, it takes a bit of a leap of faith because this isn't based on any proper data, but we've come up with this plan that if you have vasovagal syncope where not all the mitigating factors are present or occurred in an aviation environment, if you had a single episode and you had more than 2 mitigating factors, you're unfit for 3 months with a restriction for 6 months after that. If you had less than 2, you're unfit for longer. If you have 2 episodes in any 2 years, or more than 2 episodes with better mitigating factors, you're unfit for 6 months. And then if you have even more episodes, you're going to be unfit for 3 years with a restriction for 10. What level of investigation will you get? Well, for most people with vasovagal syncope, the most you will probably get is an echo, an exercise test, and prolonged ambulatory monitoring. If we really don't know what's going on, then You may end up, with tilt table testing, an implantable loop recorder, EP study. You can end up with a whole load of things depending on where the data brings you. So if you have somebody who has syncope of an unknown cause and they've got right ventricular ectopy with 2% or 3%, they'll end up having an echo, which may show some abnormality in the right ventricle. They'll end up with an MRI. You follow the whole thing through until you're happy that you've not got a major underlying condition. Implantable loop recorders, I always feel a little uneasy when I see a pilot with an implantable loop recorder because it suggests that it's not really worked out. And it's an uncomfortable moment when you have to send out the search team for the black box and the captain's ILR. So we've then come up with this, very unfriendly algorithm, but essentially the message is that if you have a straightforward episode of vasovagal syncope with all the mitigating factors, you're off for a week. If you end up with getting a diagnosis of vasovagal syncope as the likeliest cause, the more mitigating factors you have, the better, and the lower the frequency of events, the better. If we really can't work out what's going on, that the cause is unknown, you will end up having significant investigations, probably both from a cardiac and a neurological viewpoint. So my conclusions are the acceptable risk of incapacitation is the driver behind how much restriction is placed on the driver or in an aviation environment. For vasovagal syncope, the recurrence rate with non-pharmacological or pharmacological measures may be reduced, but it's certainly not abolished. And the incidence of syncope in the recent past may or may not be a better predictor of recurrence than the number of lifetime events. Drawing up guidelines for syncope in aviation is difficult as the data from clinical trials is not really directly applicable. And the use of grading the number of mitigating factors is a bit of a leap of faith as it's intuitive but not really proven. Thank you very much.